Great. Hello. Hi, everyone, and welcome. Thank you so much for joining us today. So just watching everyone pop in here, and we'll get started here in just a moment as others continue to log in. While you're waiting, feel free to connect with us on social media using the QR codes on your screen as well. And my name is Stacy Padgington. I'm the sales director here at Checkpoint EHR, and I'll be your host for today's session. So a little bit of housekeeping items before we jump in, just a few things to note. Everyone is muted to help keep the session running smoothly. So we'll save time at the end for a dedicated Q&A session. So please feel free to submit questions throughout the presentation. You'll notice there's a little box at the bottom for Q&A. So if you go ahead and select that, you can put your questions in there and we will discuss them at the end of the session. So I'm joined today by Katie Fournier, our Director of Customer Success and Operations, who will be helping moderate throughout the session as well. And we're also very excited to welcome today's presenter, Knicole Emanuel of Nelson, Mullins, Riley, and Scarborough. Knicole brings extensive experience helping healthcare organizations navigate regulatory and compliance challenges, particularly with Medicaid and behavioral health environments. So before we dive into today's topic, I just want to take a moment to share a little bit about Checkpoint EHR. So for more than 20 years, we've partnered with behavioral health organizations to help simplify operations, improve workflows, and support long-term success. At Checkpoint EHR, we believe an EHR should be far more than just a documentation system. It should serve as the mission critical infrastructure of an organization. So from clinical documentation and billing workflows to operational visibility and compliance support, organizations depend on their EHR every single day to keep operations running effectively and efficiently. So, and as organizations continue to face increasing oversight, payer scrutiny, and operational complexity, having strong systems and processes in place has never been more important. So our goal is to help providers reduce administrative burden, improve visibility across the organization, and ultimately support the people serving clients every day, and that's you. So, and next slide, yeah. So at Checkpoint EHR, we focus on helping organizations create operational consistency while reducing administrative burden. That includes things like automated billing workflows, reporting visibility, documentation support, and tools that help organizations stay audit ready. So we understand that compliance isn't just about passing an audit. It's about protecting your organization, your revenue, and ultimately your ability to continue serving clients effectively. Today's conversation really aligns with many of the challenges organizations are navigating across the industry right now. Like couldn't be more aligned. So next slide, please. So let's go ahead and shift into today's focus. So how to win Medicaid audit appeals, a practical guide for behavioral health providers. This is an incredibly important topic right now as behavioral health organizations continue to face increasing audit activity, documentation scrutiny, and reimbursement pressure. So many providers are finding themselves overwhelmed trying to navigate appeals processes while also maintaining day-to-day operations. That's why we're very fortunate to have Knicole Emanuel joining us today. Knicole brings deep expertise in healthcare law, Medicaid compliance, and audit defense, and she works closely with organizations to help them better understand how to prepare for audits, respond effectively, and protect their organizations moving forward. What I appreciate most about Knicole's approach is that it's practical and actionable, not just legal theory, but real guidance organizations can apply immediately. So with that, I will go ahead and turn things over to Knicole. Knicole?
Thank you so much. I appreciate that. And can you see my slide?
Yes.
Okay, fantastic. All right, so I'm pleased to be here. Thank you for asking me to be here. As she suggested, or as she said, I've been a lawyer for over 26 years. How did I get into this niche practice of defending healthcare providers against Medicare and Medicaid regulatory audits. Well, I started at the government level and prosecuted providers for a while. And so I know the ins and outs of how the government works going after providers for, I wouldn't even say fraud, waste, and abuse. I would say documentation nitpicking. And not all documentation nitpicking errors need to be repaid. So let's talk about that today. So, welcome and learning objectives. We're going to talk about when appeals make financial sense, common denials and audit mistakes, documentation strategies that win appeals, what Medicaid reviewers actually look for, and building a repeatable appeals process that you can use over and over and over. And we're doing this because we want to reduce unnecessary write-offs. And I want to just give a quick little caveat here. Behavioral health care is such a diverse field. You've got inpatient, you've got outpatient, substance abuse. So this presentation is going to take a broader approach rather than focusing on specific service lines or billing codes. For example, I'm not going to be discussing the nuances of inpatient versus outpatient coding requirements. Instead, I want to focus on the larger compliance landscape and why behavioral healthcare providers are increasingly being targeted for audits. The common risk areas that you need to be aware of that attract regulatory scrutiny, and practical strategies that organizations can implement to strengthen compliance and successfully navigate audit activity. It's a big topic. So why does this matter? Well, behavioral health cares are in the business of business because of business. They want to make money. I mean, obviously providers want to help people and they want to, do the right thing and help people's mental states. But in the end, they're in it to make money. That's why people work. And I want to start with a simple observation. Most behavioral health organizations aren't struggling because they're providing poor care. They're struggling because they're not getting paid for care they've already delivered. And I think that is a really, really important piece to remember. And the reality is that many providers are leaving significant revenue on the table, not because they don't deserve it, but because the reimbursement process is complex, time-consuming, and often difficult to navigate. So they end up, writing claims off too quickly. Many organizations are so overwhelmed by volume that denied claims get written off before anyone has the opportunity to fully evaluate whether they can be recovered. Lack of appeal ownership. Often everyone assumes that someone else is handling the appeal. That result is that nobody truly owns the process from start to finish, and claims just slip through fingers. You've got missed deadlines. Behavioral health teams are busy between patient care, documentation, and administrative demands. Appeal deadlines can slip by before anyone even realizes it. And then you've got incomplete records. Sometimes the care provided is absolutely appropriate, but the documentation doesn't clearly tell that story to the payer. And then we've got fear of audits. Many organizations hesitate to challenge challenge denials because they're concerned about attracting additional scrutiny or additional audits. And then finally, we've got staff turnover. Revenue cycle knowledge often lives in the heads of a few key employees. When those key employees leave, critical follow-up processes can leave with them. So, revenue leakage starts with denial management. All right, so here are some behavioral health care providers face. And as if you did not know this already, you have complex Medicaid rules that you've got to deal with. You've got frequent prior authorization disputes. And also, before we even get into this, let's acknowledge that the environment that behavioral health care providers are operating in today. I mean, this isn't a simple billing problem. It's a complex reimbursement landscape where providers are expected to deliver high quality care while constantly navigating constantly changing payer requirements. Many of the financial challenges organizations face today have less to do with clinical performance and more to do with the administrative barriers standing between services provided and payments received. So, for many behavioral health care organizations, Medicaid is a primary payer. And the challenge is that Medicaid requirements can vary state by program and even by managed care organizations. And keeping up with the changing regulations, the coverage requirements, and billing rules, it's often a full-time job in and of itself, which I mean, quite frankly, which is why I have a job, because people need to know what's going on immediately and they will call me. So that complexity increases administrative burden and creates more opportunity for revenue to slip through the cracks. At the same time, behavioral health organizations continue to face staffing shortages. Staffing shortages, I don't know about people who are listening, but my clients often run into staffing shortages often, and both on the clinical and the administrative side. And when teams are stretched thin, denial follow-ups or appeals and revenue recovery often move lower on the priority list because there simply just aren't enough days or enough hours in the day. So here is a huge myth. My denial was upheld once, so there's no point in appealing. Or my claim was denied before, so there's no point in appealing. That is a myth. It is not true. A denial is not necessarily a final answer. It is an indication that something may need to be corrected, clarified, or supported with additional documentation. And did you see my emphasis on the word may? Because quite often you also may not have anything wrong with your document, but the auditor may have just gotten it wrong. So, for example, I have seen organizations write off claims because an authorization was not attached correctly. Once the authorization information was submitted and the claim was rebilled, payment was issued. The denial was not even about the service itself, it was about missing information. Another common example involves medical necessity denials. Providers sometimes assume that a denial means the service was not medically necessary. However, after submitting treatment plans, progress notes, assessments, and other supporting documentation during the appeal process, many of those same claims are ultimately paid because the clinical record supports the care that was provided. I've also seen denials related to eligibility issues. A claim may be denied because the wrong insurance was billed or because coverage information was outdated. Once eligibility is verified and the claim is routed correctly, reimbursement is received. The lesson is that a denial should be viewed as a data point, not a verdict. Organizations that analyze the root cause of denials, correct errors, and pursue appropriate appeals often recover significant revenue that might otherwise have been written off unnecessarily. Rather than asking, this claim was denied, should we give up? The better question is, why was it denied and what action can we take to resolve it. Now, this is just a slide showing you the steps to an administrative appeal. And just note that not every state follows the same process, but in general, you will have a redetermination and a reconsideration. And I call those first two steps rubber stamps. I just do not believe that you're ever going to get a fair shake out of those first two steps. The first one is literally asking the entity that says you owe money to overturn its own decision and determine that you don't owe money. So it's kind of a useless step, but nonetheless, it is required. The next step is normally a reconsideration. This can also, in some states, go to the state agency for a reconsideration. Or some states, it could go to a contractor. A lot of states contract out services to auditors for these services. And so you may have to do a reconsideration to what may sound like a private company, but isn't really a private company. For example, a company called Public Consulting Group, or PCG, is a company that some states hire to perform Medicaid provider appeals. So it could be a private company that is just acting on behalf of the state. And then after you ask the state to reconsider its own decision, you usually have an administrative appeal, and that's normally in front of an administrative law judge, which is supposed to be or considered to be an independent tribunal. However, in my experience, I don't necessarily think that they are 100% independent, because their paycheck still comes from the state agency who's making these determinations, in most states, rather. Once you get through that, you can go through, a fair hearing with the administrative law judge, and then the state final review. Some states allow the Office of Administrative Hearings to have a final decision, and then the state doesn't have to have another review. And then some states, the fair hearing decision has to go to the state to do a review, and usually it gets overturned. And then you can go to judicial review, which is at the federal, state, district level. And that's when you get a real judge and you get a real independent tribunal, and you really do get success. It is disheartening that it takes this many steps to get to the judicial review, which is where you're going to have the most success. But that's how it is. And I always say at this point in a webinar or a seminar or a presentation, if you don't like the process, call Congress. All right, so the next slide is, when should you appeal? And if I'm just answering this slide with my own personality, my own knowledge, my own expertise, my own specialization, I'm going to say always, unless you didn't provide the service. I mean, if you provided a service and the service is medically necessary, you should be paid. The end. The end. But because it's regulated, we have to make sure that the documentation meets all these requirements. So even if your document does not meet all the requirements, that does not necessarily mean that you should not get paid. And how I said that was probably really awkward. But what I'm trying to say is, if you provide a service, that service is medically necessary, the person, gets the service, even if your documentation is not perfect, in no world should you have to pay back 100% of that reimbursement. You provided a service. I mean, you don't just not get paid for a service here in America. And also, another reason that I say this is that once you pay an alleged overpayment, you become a sitting duck or a low-hanging fruit. these auditors are paid financially on contingency fees, most of them. So when they find somebody who's going to pay, they're going to be like, oh yeah, well, we're going to go back to them. So whatever phrase you want to use for a target on your back, that is what you become when you just simply roll over and pay. I actually had an oral surgeon who was audited years ago, and he was told that he allegedly owed $500,000. And he was also told that if he did not hire a lawyer, that he could just pay half the amount. So he did. He paid $250,000, never got a lawyer, and he paid half. He very, very angry that he did it, or he was very angry that he did it. Next year, he was audited again, and the auditor said that he owed some nominal amount. I think it was like $5,000 or something like that. He appealed and appealed and appealed. He was not going to give that company one more dollar. So he appealed it all the way until it was found that he did not owe anything. And he was like, don't even care about the attorney's fees. I was not going to give them one more dollar. Okay, so this is when you may not want to appeal. If you're actually missing required authorizations, if you don't have any supporting documentation, if it was truly a provider billing error, clear coverage exclusion, or the cost exceeds likely recovery. Even if the last one, cost exceeds likely recovery, I still think that you should still appeal because you don't want to look like you're a low-hanging fruit. But for the other ones, when you are an obvious error, you probably don't want to appeal. And in this instance, I would actually suggest a self-disclosure. So per law, if a healthcare provider who accepts Medicare or Medicaid realizes that they have done something that is non-compliant or in violation of the regulations, they are bound by law to provide a self-disclosure. And you're also bound by law to do certain self-audits. And self-audits may show certain errors, but not all errors meet the threshold of doing a self-disclosure. But in a case that you have already been audited, you already see that there's this missing documentation, or you already see that there's no supporting documentation, or you already see you're in the wrong in some way, you may want to provide a self-disclosure after speaking with your lawyer. But also remember, I also said that not all documentation errors equal 100% recoupment. I also think in a situation like this, your attorney should be able to negotiate a lower amount to be owed. All right, so here are some common behavioral health denials. One of the most common themes we see in Medicaid audits is that organizations often provide appropriate care, but the documentation doesn't fully support the claim being billed. The challenge is not that auditors don't evaluate what we intend to document, they evaluate what's actually in the record. So medical necessity. I will say another thing about medical necessity is that in my mind, medical necessity is subjective to a degree, and it also should be peer-to-peer review. I have had medical necessity determined by, dental hygienists for oral surgeons or registered nurses for MDs. And I think that that is inappropriate. I think that medical necessity decisions need to be peer-to-peer, and you need to know whether your medical necessity, if you get a claim denial for medical necessity, you need to know whether the person who denied that claim had the same experience or education that the person that provided that claim. Another common denial is authorization denial, saying that you didn't have prior authorization or you didn't timely file. Duplicate claims are common. coding errors, and coding errors I still think are subjective because there's a lot of subjectiveness between coding errors, levels, 1, 2, 3, 4, 5 in certain code CPT codes. Okay, so medical necessity is the number one issue, as I discussed. Most issues rise or fall on medical necessity. Obviously, on the provider side, we're going to have the provider testify that the service was or was not medically necessary and why. And sometimes it helps to also have another peer also testify that it was or was not medically necessary. And also always look at who is reviewing and determining medical necessity. What reviewers want to see? They want to see strong records. What was wrong? How severe was it? What treatment was provided? Why was it needed? What was the outcome? The provider's argument is always going to be Medicaid's purpose is to pay for medically necessary services that were actually provided to eligible beneficiaries. If the service occurred, was medically necessary, and benefited the patient, the government has suffered no financial loss merely because the documentation was imperfect. However, Medicaid agencies and auditors are going to say, well, documentation is the evidence that proves the service was provided and medically necessary. If the record does not support the claim, the provider has not met its burden of proof. So for your presentation, you could frame it this way. You've got the provider perspective and you've got the auditor perspective. You've got to just argue the provider perspective. So this is an example of a failed appeal. There's a denial, and the denial says, well, the therapy is not medically necessary. And the documentation only says, patient's doing okay, continue therapy. There's no clinical detail at all. How can anybody glean from this note that any clinical detail that is going on? So a successful appeal is going to be a document that includes symptoms, functional limitations, risk factors, treatment goals, progress assessments. So that way medical necessity becomes clear. You see that all these extra additional information that you add on to a claim is going to be better for an auditor to understand. Going back to the last one saying patient doing okay, continue therapy, versus if you have the symptoms, the functional limitations, risk factors, treatment goals, progress assessments. Not saying that this slide is the key to documentation success, but I think if you have all these factors in a note, and the note is probably going to be successful. So, all right, the cost of poor documentation. You're going to get denials, you're going to get recoupments, you're going to be risk of being audited, you're going to have extrapolation exposure, and you're going to have compliance concerns. And not even included on that is the False Claims Act allegations that you can also suffer. So documentation equals revenue protection. All right, so the appeal mindset. Don't ask, why did they deny us? Ask, how do we prove that they are wrong? And how do you do that? You go through the law, and there's a hierarchy of law when it comes to Medicaid law. So the Social Security Act is the foundation for Medicaid law. And Medicaid exists to pay for medically necessary services provided to eligible beneficiaries by qualified providers. So key provisions often cited include Medicaid state plan requirements, medical necessity requirements, provider participation requirements, and overpayment recovery provisions. But you see at the very top of Medicaid law is the Social Security Act. under the Social Security Act are going to be federal Medicaid regulations. These are going to be federal regulations that apply nationwide to Medicaid law, normally found in the section of 42 CFR. CFR means the Code of Federal Regulation. So it is in the Title 42 of the Code of Federal Regulation, and then it'll say, what section after that. But that's where you're going to find the Medicaid regulations. So again, you have the hierarchy: Social Security Act, federal Medicaid regulations. Then after that, you have the state Medicaid plan. The state Medicaid plan is obviously, you need to follow it, and you need to follow it and make sure that you abide by it. But is it law? No, not really. The Social Security Act and the federal Medicaid regulations are law. The state Medicaid plan is an important authority, and every state Medicaid agency has a state plan amendment and billing coverage and coverage policies, but these are policies, not law. And then even under those state plans are provider manuals. And sometimes these are the most heavily cited sources during audits, because in your specific manual, like the substance use disorder manual or managed care provider handbooks, those are all things that you're going to point to during an audit, but it is not law, and you need to make sure that you remember that. Some of the most common provider mistakes, and I've probably already spoken about most of these, is missing deadlines, appealing without strategy, sending in incomplete records, using emotional arguments, ignoring policies, failing to track outcomes. As soon as you get a letter that alleges that you owe money, or that your contract is terminated, or whatever it is that they're saying, immediately assign somebody to be the head person to track this. So this, say it's dated June 28th, 2026, and you received it July 3rd, 2026. You've got to have a stamp on that to make sure that you know when you received it, because a lot of the deadlines in Medicaid law is based on receipt of documents. All right, so mistake number one is sending the entire chart. You don't want to send them everything. I mean, do they really need to see, every single thing from the last 6 years on? They ask for a certain data service. They ask for a certain reason. So just give them that data service, make sure that it tells a story, and give them it organized. Don't just haphazard send them documents. Send them organized so that they know what they're looking at. So mistake number two is to not have an appeal narrative. Many providers just simply submit records. That's not the best approach. I would include a cover letter and explain, background, why this is true, why you think this is true, why this should not be denied, why this is clinically medical necessary. And to not just simply submit records. I would go even a step further than this and say, this is the time to hire a lawyer. I'll tell you, most of my clients come to me after they get a letter that says, you owe $55 million. Let's pay it in 30 days. Give it to us now. But I would much rather get hired at this level when you're submitting records, so that I can keep a record of what has been submitted. I can tell the client whether or not they're missing anything. I can tell the client whether or not the records are compliant. And not only that, this is even better. The response then comes from a law firm letterhead. instead of coming from the behavioral healthcare provider's letterhead, it comes from, a law firm's letterhead who is known in this industry to be a powerhouse to defend providers in this arena. So I don't think you should just submit records. I think you should give us response, but even more of a punch in the face would be to have your attorney send it in. Mistake number 3 is ignoring payor language. You need to make sure that you are familiar with the manuals, with the regulations, with the contracts, with the policies. You need to make sure that you integrate the language that they use in those policies and manuals into your documents. Now, I'm saying don't ignore payer language, but also know that medical or Medicaid manuals are not law. So you cannot be held, like if you're accused of a violation of a Medicaid manual, that's not going to be a penalty that is going to be held against you, as in like if you violated a law. That's why I went through that hierarchy before. So to build a winning appeal, you need to understand the denial. You need to understand why you were accused of owing money, or why you were accused of getting your contract terminated. Whatever it is, the adverse decision, you need to understand why it was done. And then you need to gather records. And this is not you by yourself. This is you with your lawyer. You're going to gather records, pertinent records that are germane to proving that you should win the appeal. And then you also identify the regulations, make sure you cite to the regulations, and write a narrative, explain why you deserve to not have a denial, and to have that overcome or overturned rather. And then make sure you submit timely. So a strong appeal letter is going to have beneficiary information, but redacted. Redacted. You're not going to put beneficiary information without redacting the information. So perhaps initials. You'll have the claim details. What claim was it? What was the CPT code? What exactly was the claim that you were trying to submit? And then here's your statement. This is what happened. This is why we deserve to get this overturned. This is the clinical summary, and this is with the support that supports it regulatorily. And this is what we want. We want it to be overturned. So you want to write the appeal knowing what the reviewer is going to be thinking. And you have to remember that the reviewer, they're busy. They're so busy. You're not the only person or the only company they're auditing. They're auditing multiple, because remember, the more they audit and the more deficiency they find, the more money they make. So they're paid on contingency, and I'm saying that loosely, but they, being the companies, are paid on contingency, not necessarily the auditors. But you have to remember that the auditors or the reviewers are very busy. They're going to have large caseloads. They're going to have sadly limited clinical expertise. That's going back to my example of the registered nurse, determining medical necessity for a MD. And because of this, you want to spell it out for them. You want to make sure that everything is organized by consumer. Make sure, whatever they said was denied, highlight it. Say, this is where it is. It's right here on page 3, paragraph 2. Make sure that all they have to do is pick it up, look at it, and easily go through it. And is that your duty to do? No. It's not your duty to do, but if you want to get through the audit without having to hire a lawyer at the end, then you want to do as much as you can to make their job easier. That's what you want to do, is just to make their job easier so that you don't have to deal with it on the back end. Okay, so here is an example of an appeal structure. This is something that you learn in law school as well, as you always start with an issue. What is the issue? The issue, and what are the facts? What are the facts to support that issue? And what's the clinical need? Sorry about that misspelling right there. It needs a little A between the C and the L. What's the policy support? What's the requested outcome? Simple wins. A nice, easy appeal structure. Now that's for independent or individual structures. So I also want to talk to you about kind of like an overall strategy. So going back to the last slide, this is hitting the individual claim. Individually, what do you need to say for each one to win? Now, on a global appeal strategy, instead of focusing on the single claim focus, we can focus on broader strategy. Now, two important concepts that frequently arise in the healthcare reimbursement disputes, excuse me, are the treating physician rule and what is commonly referred to as the no-fault principle. So these are broad strategic legal defenses that you can use in every single audit. And make sure that if your attorney does not bring this up, that you make sure that your attorney knows about it so that they can bring it up for you. These are two broad legal defenses for healthcare providers that are found in the Social Security Act, which, as I said before, in the hierarchy of law is at the top under the Constitution, of course. So the treating physician rule developed primarily in Social Security disability law. Historically, adjudicators were required to give significant weight to the opinions of a treating physician because that physician had an ongoing relationship with the patient and was considered uniquely positioned to evaluate the patient's condition. While Social Security regulations have changed and no longer automatically grants controlling weight to treating source opinions, the underlying concept remains influential. Providers who maintain consistent, well-documented treatment relationships often have stronger evidence to support the medical necessity and the appropriateness of care. For healthcare providers, the practical lesson is that contemporaneous documentation, treatment plans, progress notes, assessments, and ongoing clinical observations carry substantial evidentiary value when defending services during audits, appeals, and reimbursement disputes. Another principle frequently discussed in reimbursement matters is the concept that providers should not be penalized for errors outside their control. Although there is no single statutory no-fault rule that applies universally across all Medicare and Medicaid claims, federal law and administrative decisions have recognized circumstances in which providers may avoid liability when they acted reasonably, relied on information believed to be accurate, and did not knowingly submit false or improper claims. Examples include reliance on incorrect eligibility information supplied by a government agency or payor, administrative processing errors made by the payor rather than the provider, claims affected by clerical mistakes that are corrected once identified, situations where providers exercise reasonable diligence and complied with applicable regulations. These concepts are particularly important during audits because they shift the discussion from whether a payment issue exists to why it occurred and whether the provider acted reasonably and in good faith. The key takeaway for providers is that successful audit defenses are rarely based on technical legal arguments alone. They are built on strong documentation, evidence of medical necessity, compliance with applicable regulations, reasonable reliance on available information, and a demonstrated commitment to corrective action when issues are identified.
Hey, Nicole, just wanted to pop in and let you know we got about 15 minutes left.
Okay, thank you very much.
Mhm.
Okay, so preparing for audits before they happen. When providers think about audits, they often focus on how to respond once an auditor arrives. A more effective approach is to prepare long before an audit occurs. The organizations that fare best during audits are usually those that have built compliance into their daily operations rather than treating it as a periodic exercise. First, conduct regular internal audits. Review a sample of records each month to ensure documentation supports medical necessity, treatment goals, interventions, progress, and build services. Finding your own mistakes is far less costly than having an auditor find them first. Second, focus relentlessly on documentation quality. If it's not documented, auditors generally assume it did not happen. Notes should clearly connect the client's diagnosis, symptoms, functional impairments, treatments provided, and measurable progress. Generic, repetitive, or cloned documentation is a common audit trigger. Third, establish a formal compliance program. This includes written policies and procedures, designated compliance oversight, staff training, reporting mechanisms for concerns, and corrective action processes. Regulators frequently functioning compliance program as evidence of good faith efforts to comply with applicable requirements. Fourth, verify medical necessity from the start of treatment and throughout the course of care. Auditors often focus less on whether a service was provided and more on whether it was medically necessary. Providers should ensure assessments, treatment plans, and progress notes consistently support the need for services. Fifth, train staff regularly. Regulations, payer requirements, and documentation standards change frequently. Ongoing education helps prevent errors that can accumulate over months or years after being discovered. Six, monitor billing trends and outliers. Providers should periodically review utilization patterns, service frequencies, modifier usage, and high volume billing codes. Significant deviations from peers or historical patterns may attract auditor attention. Seventh, respond promptly to identified problems. Organizations that discover errors and implement corrective actions are often viewed more favorably than those that ignore warning signs. Documentation of corrective actions can be valuable evidence during an audit. All right, the power of trend analysis. And this is more important if you, for example, get paid by more than one payor or more than one managed care provider. If you get denied, track it. Track the denial reason. Track who denied it. Track the service type and track the outcome. Patterns can reveal opportunities on how to fix things going forward. Building an appeals team. I think I hit on this earlier, but make sure that there's one contact person for outside counsel. There are so many people involved in a kind of investigation or a self-disclosure or audit. There's clinicians, there's review cycle staff, compliance, legal counsel, leadership. Just put one person to be the contact for the outside counsel. It does not have to be general counsel. Sometimes it can be an assistant, but just pick one person. An appeals playbook. Now, this is mostly going to be for your general counsel or your or your outside counsel, but you definitely need to make sure that you keep templates. How did you appeal? What did you use? What form did you use? How did you do the first one? Remember, the first one is the reconsideration, then there's the redetermination. What did you use to submit those appeals? What were the timelines? Were they required within 30 days? Were they required within 60 days? If something did not occur in the timely fashion that it was supposed to, is there an escalation pathways? Are there checklists? Now, these are all things that your attorney can help you with, but they're all pertinent and absolutely necessary when you're going through appeals. Now, other metrics that organizations should track would be like, how many appeals are you going through? How many claims are you appealing? What's the volume? What's your success rate? How many dollars have you collected? Basically, what is the rate of return? You want to know how much money you're spending to get money that is owed to you. And what's the turnaround time? And then that way you can help measure performance and whether or not you should go the audit route, which of course I'm going to say you should. Now here's a case study number 1. There's a behavioral health clinic, and it had its initial denial based on medical necessity. Now it recovered $145,000 because it had a strong clinical narrative and documentation. You've got to make sure you've got that strong clinical narrative and documentation in order for you to recover money that is owed to you. Another case study would be a community mental health provider. When all the audit findings are challenged, the outcome was a large overpayment demand reduced significantly. Audits matter. If you appeals matter. If you receive a high audit, always repeal. It's going to go down. It's not ever going to go up. Now, this is a case study number 3 for substance abuse or substance use disorder program. Start with the denial reason. Don't guess. Every appeal should be laser matched to the denial code or narrative. Common substance abuse disorder denial reasons include not medically necessary, insufficient documentation, a level of care not supported, no authorization or authorization mismatch, non-covered service, benefit exhausted, or missing progress or treatment plan. If you don't anchor the appeal to this language, reviewers will often reject it without full review. Also, rebuild medical necessity in 3 to 5 sentences. Auditors and payers want a tight clinical justification, not a narrative summary. You want to just explicitly state, diagnosis, substance disorder, plus any co-occurring mental health condition, current severity, withdrawal risk or relapse risk or impairment, functional impact, work, safety, housing, relationships, and why a lower level of care is not sufficient. Example, client meets criteria for continued SUD treatment due to ongoing relapse risk, impaired judgment, and inability to maintain sobriety in a less restricted setting, as evidenced by continued use patterns and psychosocial instability. All right, going to the next one. Payers are looking for medical necessity. They are looking for compliance, accurate billing, appropriate level of care, and documentation consistency. A defensible chart should answer, would an independent reviewer understand the patient, the condition, the treatment, the outcome? and 5 questions before every appeal. Is payment legally supportable? Is documentation adequate? Is recovery worth pursuing? What evidence supports us? What is the strongest argument? And those are all questions that you should be able to answer, or your attorney. And the key takeaways is do not write off claims automatically. Build systems, track outcomes, use evidence, know the rules, and appeal strategically. And resources and next steps: review denial trends, audit documentation, create appeal templates, train staff, develop escalation pathways. And I believe that is a perfect end to this presentation time-wise. I also have been asked multiple times at other presentations whether I can represent providers outside of North Carolina. And I have looked back at my client base over 20-something years, and I have represented providers in 43 states. So it doesn't have to be North Carolina. I hope you enjoyed this.
All righty. Thanks, Nicole. Yeah, so we do have a couple of minutes for questions. If anyone has those, please be sure to type them in the Q&A section. I posted a couple of times in there, so I will monitor that for the next couple of minutes. But in the meantime, Nicole, can you tell us what type of Medicaid audits are you seeing frequently right now?
So the most part, they're going to be RAC audits. Those are recovery audit contractors. Those are the contractors that are hired by the state and based on contingency. I've also seen a lot of UPIC audits. Those are the audits that are done more with education in mind, although I'm not really seeing a lot of the education in mind, more of the alleged overpayments. And that, and then I guess the perm audits. Those are the main audits that I've been seeing.
Okay, great. What would you say are the biggest risk areas for behavioral health providers that they should be paying attention to?
Behavioral health providers need to be cognizant of how much they bill according to their peers. You need to make sure that, or maybe you have reason to be at the top, but if you're at the top billing outlier, then you're going to be audited. So just be cognizant of how much you're billing according to your peers. And if it's different, then have a reason for it.
Okay, great. Are there documentation issues that you see that most commonly lead to recoupments?
The documentation issues are the things I went over in my presentation. It's going to be, inadequate explanation or a missing signature or a missing date and stuff like that. And those necessarily are not reasons to pay back money, even if you're told it is.
Okay, great. Let's see. We do have some questions coming in. If the slide deck will be emailed to us, so everyone will get a copy of the recording after the presentation. Not right after. I think maybe by tomorrow morning. but yeah, everyone will get a copy of that recording. Okay. Yeah. So it looks like you covered the topic very thoroughly because I don't see a lot of other questions here. Yeah, so what's one thing that you would love for providers to walk away with today?
The knowledge that you have the right to appeal if you get an adverse decision.
Awesome, great. All right. Well, yeah, so thank you everyone for joining us today. Special thank you to Nicole for sharing your expertise and insights on such an important topic. We all know that Medicaid audits and compliance, it can feel really overwhelming at times, but our goal is to always provide you with the resources and education that can help your organization operate with confidence. So we appreciate you spending part of your day with us. We hope you found today's session valuable and walked away with some practical takeaways. Yeah, so thank you again for being here, and we hope to see you at a future Checkpoint webinar. Have a wonderful day.
Thank you. Bye.
Thanks.